Hi, my name is Matt Rederer. I'm the founder of Right Advantage. Today we're going to talk about burns and heating in MRI. Faraday's law of induction is what we need to understand in MRI, and in order to understand that, we need to grasp the idea that if we have an electrically conductive material and a changing magnetic field, we can induce a current in that electrically conductive material. So let's take a look at an example of that. So in this experiment, we have a galvanometer with magnets and coils of wire. There's no batteries or any electrical components outside of this simple circuit. And if I spin this magnet, we can see that a current is induced in these coils of wire. And this is a product of Faraday's law of induction. In order to understand these concepts, we need to understand Ohm's law. Ohm's law describes the amount of resistance in a circuit. And in order to understand that, we need to grasp the concept of voltage, amperage, and the resistance. So by understanding that relationship, we can get a good idea of what's happening within our patient and in a circuit in general. So let's start by comparing this to the analogy of water flowing through a pipe. Voltage would describe the amount of pressure flowing through that pipe. Amperage would describe the amount of water flowing through that pipe, and resistance would describe the resistance of water flowing through that pipe. Now let's put this together. We expose our patient to a time-varying magnetic field, and we have two of them in MRI. The first one is our gradient magnetic fields, and that really doesn't hold any risk of heating in our patient. The radio frequencies, however, do. And so in order to understand that interaction with our patient, we need to understand how voltages are induced in our patient. And this is where Ohm's law comes into play. We worry about the conductivity of tissue in our patient and the permittivity of our patient as well. Conductivity. Conductivity represents the amount of current, or the ability for current to flow through a tissue. And there's a proportional relationship between temperature rise in our patient. Permittivity describes the amount of resistance to electrical fields within our patient. And that has a squared relationship with temperature rise. Now we worry about these electrical currents traveling through our patient. When we expose our patient to a radio frequency, we're exposing them to a magnetic field and an electrical field. The magnetic field helps us produce resonance in our patient and helps us get an image. But the electrical field causes all this heating in our patient, which is an issue in MRI. The specific absorption rate is not a concept reserved for MRI. Manufacturers have to test for the SAR of products and equipment that produce energy. This includes different devices such as cell phones, laptops, smartwatches, and Fitbits. It is important to make sure that the SAR do not exceed the limits on the general public. The energy that is emitted from these devices are absorbed in tissues. It is not uncommon for a laptop on your legs to heat up your thighs, or a cell phone against your ears to heat it up. In these situations, distance between your device and your tissue is your best defense. In MRI, this cannot always be achieved. As our patient takes in this energy, this radio frequency energy, we have the electrical fields which are deposited in the surface of our patient. But then we have this magnetic induction within our patient. So we're depositing energy in our patient. And this is happening over a period of time. And we use the unit of measurement watts to represent this. And now we have to also take in consideration our patient mass. And we measure that in kilograms. And so when we talk about energy being absorbed by our patient, we're talking about SAR, specific absorption rate. And that's measured in watts over kilograms. And I just want to stress the fact that this is an estimate. This is not an accurate value. And if we were going to look at an accurate value that would represent the amount of energy we deliver to our patient, we would talk about the value B1 plus root mean square, RMS. Now the B1 stands for the RF energy, the RF pulse. The plus stands for the energy yielding component of the RF. And the RMS, root mean square, represents this whole thing averaged over 10 seconds. And so the B1 plus root mean square basically means that we're sending energy and we're averaging that energy over 10 seconds. And that's what that value means to us, and it's measured in microtesla. So SAR defines what the energy per mass will be for each sequence. This means that if we have a SAR limit of 2 watts per kilogram for an exam, we would have a limit of 2 watts per kilogram for an axial T1 sequence, a limit of 2 watts per kilogram for an axial T2 sequence, and so on. It is important to note that these limits are over a 6-minute period of time. The specific energy dose, or SED, defines what the total energy deposited in our patient will be over the entire exam. This means that this will define the total collection of energy produced from each of our sequences. Since these parameters are not dependent on a period of time, we do not use watts per kilogram to define this value. We use joules per kilogram to define SED. Again, SAR is something that we like to use in MRI. It's something that we primarily use to describe the amount of heating we're giving our patient. SAR is an estimate. It's based off the conductivity of our patient, the permittivity of our patient, how big our patient is, and the body habitus of our patient. Now, we also have to understand the energy we're giving to our patient, such as the flip angle, the duty cycle of the RF that we're giving our patient. When discussing heating in MRI, in terms of SAR, our main concern is heating the patient's core temperature up to a point where it causes heat stroke. And up to this point, there's been no cases of heat stroke associated with MRI. And so let's talk about this further and how the body can actually regulate this heating that we're adding to our patient. As we expose our patient to RF, we worry about producing heating in our patient. More specifically, our major worry in terms of patient heating is increasing the patient's core temperature. Luckily for our patient, they have their thermoregulatory system to help combat this heating. Let's discuss this. Evaporative cooling describes when our patient sweats, which will evaporate and cool our patient. Convection describes when heat from our patient moves away from our patient and circulates cool air to replace it. Using a fan on our patient can create this effect. Conduction describes when blood and capillaries near the surface of our patient are cooled and sent through the body. Placing an ice pack on our patient can enhance this effect. Radiation describes when we allow our patient to radiate heat off of them without adding any more energy. All of these will help cool our patient. There are factors that can reduce the effectiveness of the thermoregulatory system, such as patient age, medications such as beta blockers, sedatives, vasodilators, and constrictors. We also find that other health conditions such as diabetes, hypertension, and heart disease can cause a patient's thermoregulatory system to be compromised. The parameters we select can influence heating in our patient. The type of RF coil we use can make a difference. We have the option to use a receive-only RF coil, which will only collect signal from our patient, or we can use a transmit-receive RF coil, which will produce RF and receive patient signal. This is also called a local coil. The patient's size and shape will influence heating. This is one of the areas that make it challenging to calculate SAR. The tissue conductivity and permittivity also contribute to the amount of heating seen in our patient. The environment also plays a role in patient SAR. The ambient temperature and humidity will influence how well our patient thermoregulates. The IEC document discusses that we should keep the room temperature under 25 degrees Celsius. Also, a relative humidity of less than 60% should be performed. Power to our patient, and therefore heating, increases approximately as a square of the frequency. It also increases as a square of the field strength. Patient size also has a square relationship with power to our patient. There are lots of ways to reduce SAR by using parameters. One is using TR. This explains one excitation pulse to the next. If we increase our TR, we allow more time for patients to thermoregulate and release energy. Another tool is to increase our echo spacing. This describes the distance between echoes. Many pulse sequences use a 180-degree RF pulse to generate an echo. By increasing the echo spacing, we increase the distance between 180-degree RF pulses. This can be done by decreasing the receiving bandwidth or increasing the frequency encoding. The flip angle controls the amount of energy that we will deliver to our patient. The lower the flip angle, the less heating we will produce in our patient. There is a square relationship between heating and flip angle. A 180-degree RF pulse holds 4 times the energy as a 90-degree RF pulse. Lowering your flip angle can affect your image contrast, though. RF and MRI produces the heat in our patient. Each slice represents a K-space or data space. We fill each line of K-space with an echo. It takes an RF pulse to produce an echo for most sequences. The less slices we have, the less echoes we need. Therefore, the less RF pulses we have. This means less heating in our patient. When performing a fast spin echo, we use multiple 180-degree RF pulses to produce multiple echoes within a given TR. The number of echoes, and therefore 180-degree RF pulses, will be controlled by the parameter echo train length. By lowering this value, we can reduce heating as long as we do not change our TR. When we fill a K-space, we need to place echoes in each line within it. Half Fourier is a technique where we only fill greater than 53% of the K-space and fill the rest with zeros. This will require less RF pulses for most sequences and therefore reduce heating. This can reduce the quality of our image, however. When setting up our scan, we have the option to set the detail in our image by selecting how many phase encoding lines we want in our image matrix. Each line requires us to place an echo within it. Most pulse sequences require an RF pulse to generate an echo. We can slightly reduce our heat by reducing the number of phase encoding lines in our image matrix with spin echo sequences. This will have the consequence of reducing our resolution. How we deliver our RF pulse determines how much heating will be produced in our patient. The duration of the RF pulse will have an inverse effect on heating. A longer duration RF pulse will help lower heating in our patient. We sometimes refer to this as a soft pulse. Each manufacturer refers to this parameter differently. The consequence of this is that it could possibly increase scan time. Parallel imaging is a technique that allows us to scan quicker at the cost of our signal to noise under specific conditions. As long as we have more than one receiver coil element in the phase direction, we can collect information from our patient from two or more elements at the same time. Rectangular field of view is a parameter that allows us to reduce the size of our field of view in the phase direction. The benefit of this is the savings in scan time. However, it is performed by omitting lines of K-space. This will allow us to reduce the number of RF pulses we need and slightly reduce heating in our patient. There are many ways we can suppress the appearance of fat in our image. One common way, called chemical presaturation or fat saturation, requires us to utilize multiple RF pulses prior to our excitation pulse at the frequency of fat to suppress that signal. These additional RF pulses prior to our TR increase patient heating. We have the option at times to null areas within our image with the use of a spatial presaturation band or SAT band in our image. This is performed the same way as with a fat saturation technique. However, our pre-RF pulses are at the frequency of the tissue we want to suppress. These additional RF pulses prior to our TR increase patient heating. The IEC document has defined modes of operation which limit both the whole body RF and local RF delivered to our patient. There is normal operating mode, which describes SAR limits meant to not cause physiological stress to our patient. First level controlled operating mode, which may cause physiological stress to our patient, but within specific limits in a routine clinical setting. Second level controlled operation mode exceeds the limit of first level and will be reserved for research MRI. Another area that we can use to help reduce SAR in our patient is the pulse sequence. When trying to understand the relationship between heating and the pulse sequences, we must look at the RF configuration in our pulse sequence. This describes how we excite hydrogen in our patient. There are two types of pulse sequences that will generally promote the largest increase in RF heating. The first one is the spin echo sequence. To keep this simple, let's only look at the fast spin echo to get an understanding of this concept. The fast spin echo uses multiple RF pulses to accurately sample the decay of transverse magnetization. This has the benefit of giving us true T2 contrast in our image. To accomplish this, we must utilize multiple 180-degree RF pulses. Each of these adds significant heating to our patient. The number of 180-degree RF pulses we use will be determined by the echo train length. The more 180-degree pulses we have in a given TR, the more heating we will be delivering to our patient. This is, however, influenced by our echo spacing and the length of our TR. The second one is the steady state gradient echo. To keep it simple, we will be general with this type of pulse sequence. For these sequences, we are typically using an RF pulse less than 90 degrees, and we do not use a 180-degree RF pulse. We would expect this to provide less heating in our patient. The issue becomes how long our TR is. Many times our TR can be less than 500 milliseconds. This means we are delivering an RF pulse to our patient without giving the patient time to dissipate the additional heating. This can produce higher SAR values in our patient. We will allow Hulk to help us understand absorbed energy. We have painted him with a thermosensitive paint, and now we'll expose him to an energy produced from a light source. As the paint color changes, we can see that energy is being absorbed depending on how long we expose him to it. Two parts to SAR and hotspots. Energy absorption on the surface of our patient can lead to localized areas of heating. This is related to the time of exposure. The other part is the induction within our patient. As eddy currents travel through our patient, areas where tissue with high conductivity, like muscle, meet areas of low conductivity, like fat or bone, can often create higher chances of localized heating, called hotspots. These can manifest in two ways. One is collections of electrical fields in our patient, and the other one is collections of electrical fields that produce temperature increases. Implants in our patient can disrupt electrical densities and produce hotspots. The birdcage RF design was selected for MRI because it meets the needs of RF exposure. The birdcage coil consists of end-rings and legs, also called rungs. Each leg connects to the end-ring and is a parallel conductive segment. We will find any number of legs ranging from 8 to 32 on an RF birdcage coil. There are also capacitors used on a birdcage coil. Depending on its design, we will find them either on the legs or the end rings. Most commonly, these are found on the end rings. The capacitors help isolate the B1 frequency and can heat up significantly during acquisition. The port feeds are found on the end rings and are 9 degrees apart from each other. These help with our transmit frequency. The birdcage coil must be shielded, and we commonly find that the diameter of the coil is approximately the same as the length of the coil. The birdcage coil will produce electromagnetic fields that emit from the legs of the coil. This will produce resonance in our patient, but also produce heating in our patient. The field near the birdcage coil will hold higher energy fields than areas located further from it. As we move into the far field, the relationship of power intensity between the electromagnetic field and distance result in the inverse square law. The near field contains more power, but decreases much more rapidly than in the far field. It is divided into the reactive or inductive near field and the radiative near field. These areas depend on the wavelength of our transmit frequency. In the reactive zone, the RF transmitter will contain the energy of the RF exposure, and due to the process of energy storage and the return effect, we see large electromagnetic fields in these areas. The electrical field and magnetic field will be out of phase 90 degrees. As we move into the radiative near field, the power intensity begins to decrease, but still holds more intensity than the far field. In terms of burns, we can compare a proximity burn to the same effect as how a microwave works. This can be explained as a dipole-dipole interaction. A microwave works by sending electromagnetic frequencies into a shielded box. Molecules are exposed to an oscillating electrical field, and this is what heats up food. As molecules are exposed to this changing electromagnetic field, atoms in our food begin to vibrate, causing friction. We call this a dipole-dipole effect. The result of this is heating. Tissues in the near field will be exposed to more intense electrical fields. This can cause higher risks of heating and burns in these locations. The far field is the area where we find less intense fields and where we can expect to have less of a risk of heating and burns. Areas near the rungs are where the risk lies with proximity burns, and when tissue is in the reactive zone, burns can occur. The goal is to move tissue outside of the reactive zone, and if possible, out of the radiative zone, to reduce these burns. This slide was provided by Dr. Frank Shellock. It demonstrates multiple images of MRI burns that are not a result of heating up conductive implanted devices in or on our patient. These burns were caused by different processes and are very serious. In order to prevent proximity burns, we implement one thing that can prevent these burns from ever happening, and that's providing a barrier of 0.5 centimeters to 1 centimeter between the patient's skin and the gantry. This moves the patient tissue outside the near field and allows us to reduce the risk of burns. Now, the caveat to this is that it has to be a pad. It can't be a towel, it can't be a pillowcase, nothing that can get saturated. A patient was undergoing an MRI exam and had tissue touching the area where the RF transmitter was located. This resulted in a burn. There were 2 points that occurred in this case that were interesting. One was the fact that the technologist did place a pad on the patient. The pad, however, did not cover the patient's contact point to the transmitter well enough, and a burn resulted. 2, the burn presented a couple hours after the MRI and was larger the next day. Using sufficient padding would have prevented this burn. This patient had an MRI of their knee and received a burn on their hip. The hip was in contact with the side of the gantry, and a 3rd-degree burn resulted. The size of the burn was 6 centimeters in size. This could have easily been prevented by placing a pad between the side of the bore and the patient's tissue. One of the largest concerns in MR safety is the heating of implanted devices in our patient. As we emit electromagnetic energy into our patient, electrically conductive implanted devices in our patient can act as antennas, focusing electrical fields. We call this the antenna effect. These electrical fields can collect around edges on devices, increasing temperatures in these locations. This can promote conditions that can lead to burns. Medication patches, metallic microfiber clothing, and conductive objects can promote this heating. The closer we get to the antenna, the more power intensity devices will receive. This means that we may see larger heating in the near field. A good example of this effect is with the induction cooker. This emits an oscillating electromagnetic field which collects in conductive materials. This causes heating. There are some differences between the way heating occurs between MRI and the induction cooker, but we can use this to demonstrate the process. If we loop a wire and attach it to a bulb, we can make an antenna that will light up when current is produced in the loop of wire. We can demonstrate how energy is transferred through the air and collected in conductive objects. The same process occurs in implanted devices in MRI. This slide was provided by Dr. Frank Shellock. It demonstrates multiple images of burns caused by the antenna effect. By exposing MR unsafe devices, which could be ECG leads, pulse oximeters, and medication patches, burns can result. This article discusses a burn to an 11-year-old who was wearing a silver microfiber undershirt. She was sedated for the exam, and after the exam, she woke to burning sensations on her skin. The burns were a result due to the RF exposure to an electrically conductive material. These caused second-degree burns to the patient. It is important to note that silver is not ferrous. This means that if we are completely reliant on a ferrite detector to detect all threats in MRI and not changing our patients completely, we may miss ones that can burn our patient. Linear structures promote heating. Temperature increases begin to occur at lengths greater than 2 centimeters. We will notice the greatest increase in temperature at half the wavelength of our resonant frequency. At 1.5 Tesla, this is approximately 25 centimeters. At 3 Tesla, this is approximately 13 centimeters. Rigid objects with edges can promote the collection of E-fields and increase temperature. We would expect spherical structures to have less heating because of this process. The location of the object can promote more heating as well. Structures closer to the RF source will offer conditions that increase the degree of heating. This means we will see higher chances of heating in the near field than in the far field. RF intensity is governed by the inverse square law. If we double the distance, we experience 4 times less energy. In order for the antenna effect to occur, the material we expect to heat up must be electrically conductive. This includes metals and even carbon fiber. Some metals can vary on how conductive they are. As we decrease the resonant frequency, we increase the penetration of exposure. This is one reason why we cannot say that a 1.5 Tesla MR unit is safer than a 3 Tesla MR unit, and vice versa. Patient conditions play a role as well. These include weight, height, electrical properties of tissues, and even blood flow. Some intravascular devices may heat up significantly when exposed to RF, but due to blood flow across the device, heat can move away from the implant much like oil carries heat in an engine. The antenna effect can be optimized when conductive materials are perpendicular to the RF exposure. Since we know that our RF transmission will be perpendicular to the B0, or direction of magnetic flux, linear conductive objects parallel to the B0 may promote an increased chance of heating. Manufacturers are bound to the terminology and testing of the ASTM when seeking approval for scanning an MRI. The American Society of Testing and Materials International provide testing requirements in MRI. Depending on what the device is made of, will determine what category it is placed in. The labeling of devices is defined by the ASTM F2503. Objects are marked MR safe if they do not have any metallic, magnetic, or electrically conductive materials within them. This means only a select few items fit into these categories. We may find that earplugs, 100% cotton shirts, and contact lenses with no pigment fit into this category. According to the ASTM F2503, these objects do not require any special requirements to scan an MRI. This means that any object labeled MR safe can be on or in our patient without any special considerations. Objects that are marked MR conditional can be a bit trickier to work with. In order to get this marking, an object would fit into one or more of the following categories. It would be metallic, magnetic, or electrically conductive. The ASTM also says that if they fit into these categories, they must have limits for any of the sources of threat to our patient. This includes the static magnetic field and the time-varying magnetic field. Again, the time-varying magnetic field refers to both the grating field and the RF field. It is optional for a manufacturer to list artifact size associated with the device undergoing MRI. When addressing the limits for the static magnetic field and time-varying magnetic field, conditions on how to scan these devices safely would be defined. Objects like wheelchairs and IV poles fit into the ASTM marking of MR conditional and would require conditions on how to scan these devices safely in MRI. If the object cannot be scanned safely under any conditions, the device would be labeled MR unsafe. Also, if an object has not been tested under the ASTM standards, it would be marked MRI unsafe. For example, a scissor, pen, and computer would be considered MR unsafe because it has not been tested. Let's focus our attention on the markings of MR condition, and more specifically, ones that pertain to the RF conditions. One common condition seen associated with the time-varying magnetic fields, which include the RF field, are the modes of operation. The IEC 606-01-2-33 defines limits associated with each mode. When looking at limits associated with the IEC for RF, it focuses on specific absorption rate, or SAR. These limits are listed for both whole body, which describe RF produced by the body coil inside the MRI unit, and ones that are listed for local coils, which are coils placed around body parts that produce the RF needed for imaging. There are two modes in clinical MRI. They are normal operating mode and first level controlled operation mode. A manufacturer may list that a device can be scanned in normal operating mode or up to first level controlled operating mode. Another RF condition may be the listing of a specific absorption rate or SAR limit on the device. This requires us to know a few details about the situation. We need to know what RF coil we are using, or will we be using the body coil or local coil. Also, we need to know where the device is located. A manufacturer may say that we can expose the device to a whole body SAR limit of 2 watts per kilogram. This means that we would make sure that we use the whole body RF coil, and we must stay under 2 watts per kilogram. We can do this by staying in normal operating mode or viewing our SAR on the console. Manufacturers may also list that scanning cannot be performed on body parts below an anatomical structure. This can make things trickier for meeting these conditions. However, understanding why these conditions are set can help the benefit risk assessment with the MRMD and or MRSE. Some devices like vascular stents can vary in length. Depending on the length and the field strength we are scanning in can promote different risks to our patient. A manufacturer may set conditions on certain limits on the size of the vascular stent and a field strength. The field strength will determine the resonant frequency and therefore what the length of our half wavelength is. The B1 plus RMS defines the energy we will be delivering to our patient. This provides us an accurate understanding of what the energy reaching device may be. This value is measured in microtesla and can be found on the MRI console. We see this most commonly with active implants. Dr. Frank Shellock kindly shared with me this slide and story in regards to this event. This patient was suffering from Parkinson's disease. As his treatment plan, he had a neurostimulator placed inside of him. He did not want to have the generator placed in his shoulder region due to personal preference, so they placed it in his pelvis. In order to have it reach the extra length, they combined leads to make it longer. The device did have MR conditional labeling and was tested at 1.5 T. When the patient needed an MRI of his lumbar spine, He presented the MRI facility a unique situation. 1. He had a neurostimulator. 2. It was not in an area that it would typically be found. And 3. The leads were made longer. Because of this situation, the risk was evaluated, and it was thought that it would still be acceptable to scan this patient on a field strength less than 1.5 T. Other conditions were ignored as well, and the patient underwent the exam. The patient received burns to his brain and suffered neurological deficits. This was a unique situation. However, it should not be assumed that scanning a patient on a field strength outside the recommended limits is safe. As we have already discussed, each field strength provides its own unique resident frequency. This is an example of a burn in MRI reported to the MAUDE database. It discusses the case where a patient was undergoing an MR knee exam. The technologist pre-screened the patient and made sure no metal was on the patient. The patient was wearing their street clothes, however. When positioning the patient, the technologist positioned the patient's knee into the knee coil and wrapped the opposing knee with an RF blanket. A few sequences in, the patient began to scream. The technologist did not hear the patient and only noticed when the patient started flailing their arms. The technologist stopped the exam and noticed smoke and a burn hole in the RF blanket. The patient said that it felt like it was getting warmer during the exam until it was unbearable. The RF blanket had copper material in it and became a conductor, which led to the burn. This is another event in which Frank Shellock had shared this image and story as a learning tool. This patient was a child who underwent an MRI exam. The parents insisted on placing a blanket on the patient, which was meant to keep the patient warm during imaging. The blanket had two sides to it, one that looked like a cloth and another that had a foil backing on it. During acquisition, the blanket began to heat up and the child received burns to his neck. This event was a tragic one which could have easily been prevented. We should not place an object that is magnetic, electrically conductive, and/or metal on our patient and scan them without knowing we can meet the specific MR conditions pertaining to that material or device. In this situation, the blanket had been tested prior to this event and was deemed MR unsafe. This entire experience could have been avoided if the blanket was not placed in the MRI room on top of this patient. Loop burns are another type of burn that we see in MRI. These induced current loop burns are generated from the RF interacting with tissue. And depending on the tissue's conductivity and permittivity will determine how they travel through our patient. Different tissues have different conductivity and different permittivity. For example, muscle has a high conductivity and fat doesn't. And so as these currents travel through our patient, they deposit heat through resistance in our patient. So we call this resistive heating. As these eddy currents travel through our patient, they look for pathways to complete that circuit. So as they travel through our patient and they come in contact with a tissue that touches another tissue, it could potentially complete that loop, that circuit, and cause a burn in that area. To simulate the eddy currents produced in tissues, we will use this hot dog and run an electrical current through it. We can see that currents are produced in tissues because of the light bulb that starts to glow. What we do not notice is that the hot dog is getting hotter because of resistive heating. Given enough time, we will cook this hot dog to perfection. Induced conductive loop burns occur when eddy currents are focused through small contact points of tissue with varying conductivity. In this example, we have a pork chop and a hot dog to simulate eddy currents through a small contact point. We can hear the sizzling of the meat and see current passing through the meat with the light bulbs which are lighting up. By having the hot dog and pork chop touching, we can form a complete circuit so eddy currents can travel through tissues. This article discusses a burn that a gentleman received on the inside of his thigh. He was undergoing an MRI of the thigh to rule out cellulitis. The man had his legs pressed together and felt a burning sensation on both thighs during acquisition. After the procedure, a 1 centimeter fluid-filled lesion was present in the area of the burn. This is an example of a conductive loop that was formed between his thighs, allowing a current to flow through a small contact point. These burns are not limited to areas of RF exposure, like seen with proximity and resonant burns. These can occur anywhere in the body, no matter where the exposure takes place. It is only limited by the conductive pathways in our patient. Skin-to-skin contact, or a conductive material forming a skin-to-skin contact point, promotes the risk of these burns. The type of contact point matters as well. The larger the contact point, like interlocking fingers, will offer a lower risk of burns when compared to a small contact point, like a finger touching a leg. Common sites for these burns are the outer thigh, inner thigh, and calves. To prevent these burns, we should place a pad between touching tissues. It is important to consider that a pillowcase, blanket, or sheet may not be sufficient. These can become saturated with sweat or water and form conductive pathways. These can lead to a burn. A barrier of 0.5 to 1 centimeter separating the skin-to-skin contact point is required. To simulate burn prevention, we will place a towel between the hot dog and the pork chop. Now we will turn on our electrical current and quickly notice that a conductive loop is not formed because the light bulbs are not lit up. Now, if we saturate that towel with water, we can see that a conductive circuit is now formed, causing the light bulbs to light up. This could create a scenario in our patient which could promote a burn. By placing a pad between tissue, we can maintain the appropriate gap between touching tissues and prevent conductive pathways from forming. This is a reported event that involved a patient undergoing an MRI exam and receiving a burn. The patient received a burn on the inside of their thighs and on a contact point between their hand and thigh. A blister of 3 to 4 centimeters in size was formed. This burn could have easily been prevented by placing a pad between the patient's thighs, as well as a pad at the skin-to-skin contact point on the outer thigh. This is another example of a burn that took place in MRI. This patient was having an MR lumbar spine and began to heat up during the MRI exam. The patient began to sweat and received a burn between their knuckle and hip. The knuckle and hip formed a conductive loop, forming a burn at this location. We could have easily prevented this burn by placing a pad between the patient's knuckle and hip. To recap, RF and MRI causes the heating and burns we see in MRI. The patient heating is a result of delivering energy to our patient. Depending on the patient's mass, we can estimate the absorbed energy in our patient with the specific absorption rate, or SAR. The B1 plus RMS tells us what the effective energy being delivered to our patient is, not the absorbed energy. The fear of patient heating is that we could cause heat stroke in our patient by increasing their core temperature. We can utilize parameter changes that can lower this effect. Burns associated with tissues in very close proximity to the RF transmitter can promote close proximity burns. These burns are common in obese patients due to situations where patient tissues may be pressed tightly against the walls of the gantry. To produce these burns, a barrier of 0.5 to 1 centimeter should be used to separate tissues from the wall of the gantry. This should be a pad and not a towel, sheet, or pillowcase. Burns associated with the antenna effect can be trickier to remedy. These require us to create situations that can promote lower heating in conductive devices in our patient. By evaluating the location, shape, length, and other conditions, we can identify the level of risk to our patient. We can then identify a plan to reduce these risks in our patient. Induced conductive loop burns are caused from eddy currents in our patient following conductive pathways. These can take current-producing tissues far from the exposure area, producing risk at locations where skin-to-skin contact is present. By eliminating the touching of bare skin in our patient by using a pad of 0.5 to 1 centimeter in thickness, we can prevent these burns from occurring. Thank you for taking the time out of your day to gain knowledge on MR safety. If you would like to receive one free Category A ARRT CE point for viewing this presentation, visit www.riteadvantage.com/free.